So I'm here with Michael Lichtenberg, and we're going to discuss the Wingman CTO catheter. Hi Michael, thanks for your time. Could you briefly explain to us what the Wingman CTO catheter is and basically how it works?
So the Wingman catheter is a support catheter which helps you to cross calcified lesion, proximal cap plaques, which are most challenging in a lot of scenarios, and with that catheter you are able to biopsy this plaque and then can forward a guide wire. So this is especially a device for more calcified lesions.
Okay. And how does the way it works differ from other alternatives?
Actually, there is no other device on the market which acts like the Wingman catheter. It is not just a support catheter. The big difference is the needle which comes out of the tip of the catheter, which then deeply penetrates the cap of the calcified occlusion and creates a channel where then you can use this channel to guide with a guide wire, and helps you then to perform the whole revascularization.
Okay. You're giving your presentation on Saturday about this device, and in the title of the presentation it talks about complex and difficult occlusions. So how complex and how long are the occlusions that we can treat with this device?
So we are seeing more and more of these complex occlusions, especially in diabetic patients or renal failure patients. And the lesion length is not only the issue, it's also the severity of calcification. And the more calcium is in the lesion, especially CTO lesions, the more you have problems to cross that with also dedicated wires. After you penetrate the cap of that plaque, it is more softer and more easier to pronounce the wire downstream. So I think this device is very helpful in these indications, and as we see more and more of these lesions in patients, yeah, we are using more and more of that crossing device. Yeah.
And in which arteries can this device be used?
So basically, you can use it in every artery of the lower limbs. I have very good experience in the SFA, particular on the popliteal artery. As it is a needle which penetrates, there is of course a risk that you penetrate the vessel wall. So I wouldn't recommend it, at least in the aortic or the iliacs, where you can't control bleedings. So SFA, popliteal artery, is quite helpful. There are different sizes of that catheter available, with usage of 35 inch guide wires or 0.8 guide wires. So there's a whole broad bunch of different guide wires which you then can use. Yeah.
Okay, and so it's very compatible with other guide wires?
Yeah.
Yeah? Okay, great. And what's your experience been so far with using this in patients?
It is very helpful. I use it if I'm not able to cross the lesion, and we always try to stay intraluminal and not to go subintimal, which is sometimes even more challenging than for revascularization. And if you stay intraluminal, then you have all options for a very successful recanalisation. Stay maybe even without stents, just debulk the lesions, just use drug-eluting balloons. But therefore you definitely need to be in the vessel, not in the subintimal space. So with that Wingman catheter, it is quite easier to stay intraluminal and perform the whole procedure in the vessel.
Okay. When people leave your presentation on Saturday morning, what's the main message you hope they take?
It is an option. It is an option, especially in these calcified complex CTO lesions. I wouldn't recommend it from the first step. Use it if you are not able to cross the lesion.
Okay, great. Michael, thank you very much for your time.
Thank you.
Appreciate it.